Hello everyone and welcome to this CADA seminar. I'm Charles Muswhite, I'm Professor of Psychology at Aberystwyth University and I'm co-director of CADA. CADA is the Centre for Ageing and Dementia Research. We're a research programme funded by Health and Care Research Wales to bring together researchers in Wales working on different areas of ageing and different areas of gerontology research, along with those in policy and practice in order to make a difference to older people's lives in Wales and beyond, make things better for us all as we age. We look at biological aspects of aging, we look at the social science of aging, and we look at the arts and humanities elements of aging, and we try and pull those things together. It continues to be an absolute privilege to be co-director of CADA and working with older people that we have and the great team that we have. And one of the really nice things we do is have these lunchtime webinars. We're reaching a wider audience than ever before with these being online, but it's still a little bit of a shame we can't do these in person and see each other. But I hope you've all got your lunch together and you're ready to listen to a really interesting and really pertinent and important research topic being discussed today. So I'm not going to do huge introductions, but the project is looking at the issues surrounding what happened to older people and their relationship to health and social care during COVID-19 and possibly beyond that afterwards. I think the project's called COSMO, which is a great acronym, and delighted that we've got Emma Richards, Mary Jones and Liv Costners to introduce that to us today. So without further ado, over to you to tell us about how we learn lessons from lockdown, the need for collaboration in age-related research. So over to you.
Okay, so in this webinar, we will describe our research ideas that we've just received some funding for. So we're going to be running a research project for the next 2 years. I'll talk you through the ideas behind the research, how lay members of the public became involved in the project, and then I'll pass you over to the colleagues to describe the project as we go through it. So the coronavirus pandemic has affected all of our lives in many ways. Primarily a public health crisis and to many a personal tragedy. We've all been touched directly or indirectly by the virus. The consequences for our economy, our society and communities have been profound. The impact of the virus has not been evenly distributed across our society. The pandemic has exacerbated existing inequalities and the most vulnerable have been hardest hit. The pandemic hit us after decades of austerity in which our public services have been starved of investment. There is no doubt that some communities have been affected more than others. So either from a health perspective, such as the Black, Asian and minority ethnic groups and disabled people, or economically, especially those working in sectors such as retail and tourism or the arts or hospitality. We know that young people in particular may carry the burden of dealing with the coronavirus with them right the way throughout their working lives. This is an extract from the government. Welsh Government recently outlined a post-pandemic strategy. However, as you can see, older people weren't explicitly recognised within this. A review of the literature also shows that there was a lot of research done on COVID-19, but there's been little focus on older people. Patients and carers and older people want to tell their stories about lockdown and the impact it's had on them. They want improved and more responsive health services. Many want to contribute to the debate around the budgets and practice in all areas of health and care and social care. It's really important, the evidence around the impact of COVID-19 and on the populations identified at greatest risk is used then to inform future pandemic responses. So what do we know so far? This helped us into developing the research questions. So there's been a direct adverse effect on over 65s overall, not just those in need of care and support due to the lack of reduced access to relevant resources. For many people, they may not have needed care and support, but these resources that were reduced or stopped has had a really great impact on them. So this included things such as closed community centres, swimming pools were closed and gyms, bus services were reduced. There were less opportunities for people to exercise. Close friends and relatives were not allowed to visit. Day-to-day tasks such as food shopping became more difficult. Did this impact people's health? I recall going to Tesco's to find toilet rolls and not being able to find any, and then having to visit 5 or 6 different shops to try and find some. Vital services become unreachable, so trying to get through to your GP for some treatment or for some advice, a lot of this was stopped or postponed. In developing our research, we involved members of the public. We advertised through CADA and through the Swansea Centre for Health Economics. We invited a carer to come onto our application as a co-applicant, and she helped us to write the application. So members of the public were involved right from the very beginning and have guided us through the research to keep the research focus broad. And later on throughout the project, they will help us to narrow the research down. In applying for funding, there was 2 stages to the application. And in stage 1, we invited lay members to look over our research proposal. So we wanted to know from them whether the research was important to patients and carers. So there's no point in doing research if it's not important to members of the public. It's public funded project from Welsh Government. So we needed to make sure that it is important to what they want. So is the proposed research looking for outcomes that are important to the patient, to service users and carers? Are people likely to take part in the research if we do it? Is the funding application easy to understand, and could it be improved? We wanted to know what a difference having public involvement made to our application. So we asked people this, and could the plans be improved? And how then will researchers make sure that the findings of the research reach the general population? So in stage 2 of the application, we successfully got through stage 1 and we received some feedback from Health and Care Research Wales. And a criticism of our first application was that the research question was too broad. So we asked members of the public, firstly, to seek advice on how we should narrow the research questions down. So should we narrow the questions to look at a group of diseases or specific illnesses? And are there any diseases in particular that we should focus on? So what was important to them and the wider community? We know NHS care is provided in 2 ways, primary care and secondary care. So primary care is the GPs and the community services. And then secondary care is the specialists and the hospitals. So should we focus on primary care or secondary care or both? Which one do they believe was most important to include in our study? So we asked members of the public if they had any examples that they could tell us of from family and friends about in which NHS appointments or care plans were changed as a direct result of the management of COVID. We had a fantastic response from our lay members, excuse me. So here they spoke about stroke patients who were losing valuable rehabilitation time due to local gyms being closed, impacting on well-being, physical health, and even then in the economy long term. There was a big impact on mental health, somebody said, waiting weeks for an emergency mental health appointment that should have only taken 1 day. People missed contact with their grandchildren, and some reported never meeting their grandchildren because they were born a few months ago and they weren't allowed to visit. Here on the slide, you can see a vicious circle of people who said they were trying to connect to the GP on the telephone to get an appointment. And even just trying to get through on the phone was almost impossible on times. And then they were subjected to a pseudo triage by the medical receptionists to see whether they needed to be seen or not. They were then given a telephone consultation if they were lucky, and then a face-to-face appointment, which was very rare. And people said this was really difficult to cope with. People reported being lonely and bored, missing tactile experiences. And they said this was heightened for those who lived alone. So middle-class people have had children and they've gone off to university and they've never come back home to live. So they don't have any children who live close by. In asking the lay people, they also said that they tended not to seek help for medical advice. But that was because they were afraid of catching COVID, or because they believed the NHS was overworked and that they were told, perhaps you really shouldn't unless it's absolutely necessary. So under both circumstances, people tended to manage at home. One really good example of lay member involvement was one person who actually contacted 8 or 9 of her friends and asked them these questions and reported them back to me. And she'd done this without any prompt, and this was a really valuable experience for us. So to look at the aims of the study, we want to understand the unintended consequences, including the harms of the COVID-19 priority management for people in Wales aged 65 and older, with a focus being on NHS healthcare resource use, the costs, the health outcomes and the lived experiences. I won't go into the objectives at this point because this will come through as each of us talk about our different parts of the study. But we were helped by our lay members to develop some research questions. So for people over the age of 65 in Wales, did COVID-19 management lead to unintended consequences in terms of the effects of health and care resource use, the costs, population, health outcomes and experiences? So we developed 8 research questions, which will come through as we talk about this in the slides. So I won't go through it now. Okay. The project then has been divided into 4 work packages, or mini projects is the way I like to describe it. So in work package 1, we are going to develop or identify specific subpopulations of older people whose needs are currently underrepresented by the available evidence on the priorities proposed by the advisory panel, which we're going to set up, and a rapid review of the literature. So the goal of work package 1 is to shape and inform the subsequent work of work packages 2, 3 and 4, which will enable focus on the research on the priority population. Work package 2 will estimate the health economic impact of the pandemic on the population specified during work package 1 using economic modelling. Work package 3, so that we aim to explore the experiences of the pandemic on the population. So we're going to be conducting interviews with older people. And in work package 4, the findings from the previous 3 work packages will develop an ethical framework for use on the ground decisions to inform fair prioritisation regarding older people in Wales during the COVID-19 recovery period and in any future health crises. So we are going to develop a stakeholder group, and we are seeking members from professional services and organisations. If you identify yourself as somebody who might be able to help us with this, you can send a private message with your email address, or if you want to suggest anybody, then please do that. We're seeking members to join our stakeholder group. So they'll be managers and coordinators from the third sector, community health councils in Wales, Public Health Wales, Welsh Government, local authorities, Welsh Health Boards. We're going to have an ethics committee member a health economist, people from NHS Finance and NHS Wales. And these will join us and our 5 lay members to advise and offer expertise throughout the research process, particularly during key study milestones. The input of many different stakeholders is essential to ensure our research is informed by those who have a stake in receipt and delivery of health and care services for people over 65. But we wanted to stay focused and of interest to the public, so healthcare professionals and all other interested parties. And as part of our meeting, we'll present the aims and objectives of our study, which will focus on identifying the priorities for investigation. So this hasn't been done yet. So the panel will guide the research with identification of key measures. We'll reflect on the findings and the development of the recommendations. We'll develop a short list of populations of interest, so around about 5 populations of interest, whether this be stroke rehabilitation, dementia services, ambulance services, primary care. This will be developed and decided by the stakeholders and our lay members, ones that are of interest. And to inform the populations that we will be identifying, there will be a rapid review of the evidence to see whether there are unmet needs and gaps in the research. And now I will pass over to Dr. Costners.
Hi, my name is Liv Costners. Can I also, I don't know, Emma, if you actually introduced yourself, but that was Dr. Emma Richards, and she's from CADA. So this work that we're doing is a collaboration that Emma mentioned. So I'm from the Swansea Centre for Health Economics, but my background is actually in psychology. And true to Swansea, which is actually a little village, which is where we all are at the moment. Emma and I actually did our undergraduate psychology degrees, well, at least the last year together. So, you know, it's nice to sort of come back to people as well. So I'm going to talk to you a little bit about work package 1. And I'm going to talk to you more so about the methodologies that we are going to be using to identify the subpopulations that Emma has referred to, and also how we are going to be looking at some of those, identifying some of those unintended consequences. So let me see if this works now. So I click, scroll. I can't seem to change the slides. Do I have control?
Yeah, if you just use your arrows on your keyboard, you should be able to go left and right now.
No. No. No, it's not doing that for me. Oh, thank you. Am I just going to have to say change slides? No, sorry, go back. Sorry, back. Oh, is that me now?
It's going wild now. Hold on.
Oh, okay. Let me try. Shall I try?
Yeah, go on.
Is it just super slow, is it?
Possibly, yeah.
Okay, well. Yeah, nothing is happening when I'm doing it. Can you get it back to the diagram? Yes, brilliant. Okay, so this is just a summary of work package 1, really. Like Emma's mentioned, and which I'm going to just say very little about here, we are doing a rapid review of the literature, and that's part of our problem analysis. It's really about trying to really gather insight into the context. Obviously, we are aware of the COVID-19 context, but also, you know, the setting in Wales, because our focus is specifically on Wales. So, you know, the first thing we are doing is really identifying the problem and the causes and what the intervention actually was in terms of managing COVID-19, particularly for those over 65 and over. Part of that is developing the program logic in terms of understanding the sort of the theory of change and why this intervention was put into practice, and, you know, what was the belief around it and how that actually would protect people 65 and over. So we will be looking at the different causal relationships there using logic models, which I will explain to you. And that, along with the stakeholder panel, or the advisory panel that we're putting together, will form our research plan and really feed into the other research, the work packages as well. So yeah, let's see, I'll try and see if I can get the next slide. No. Can you do next slide, please? Thank you. So our colleague Bernie Sewell is doing the rapid review. Bernie is a health economist with us at the Swansea Centre for Health Economics. And we're going to really be looking at the advisory panel, that's the AP acronym there, to support us in really identifying some of those topics for investigation. And, Bernie's really going to be the best one placed to look at the sort of economic modeling work, that how the data can feed it, how the review can feed into that as well. Next, please. It's important to note that the rapid review is going to be updated in the last 6 months. Obviously, there's a lot of literature produced in the last sort of 18 to 24 months now since COVID, and in the last 6 months of the project, which is going to be in 2023, we're going to review the literature again just to make sure that we haven't missed anything, because it's so it's currently being, it's constantly being updated at the moment, the literature. So we really need to keep our eye on what's going on throughout the project, not just at the start. And I noticed as well that we have somebody from the COVID Evidence Centre with us in the viewing panel today. So we will be looking at what they're producing as well as part of our literature searches. So what I'm going to talk to you about really is the logic model that we're developing. And I think logic model, so there's a few images here of maps and points and instructions and sort of guidance, and logic models are used quite a lot in program and service development and in evaluation. And there's loads of different definitions, and the one that we kind of adopted for our project is that is a graphic description of a system which is designed to identify the important elements and the relationships of that system. Particularly what we want to try and understand is some of those mechanisms of impact. And so we're looking to really, look at the underlying theory of change behind this management of COVID, to try and understand, it's fairly easy for us to see that, when we're developing a service or a program, that what we put into something, so perhaps the cost, the cost of a service, and then look at the benefits of that afterwards. But what we don't often understand is all those other bits that go in between, all the activities, all the processes, and how we get from costs to benefits. So I guess, in our context here today for our project, one of the costs will perhaps be that people were asked to shield, they were taken out of their day-to-day lives and their context and told to stay at home. And the outcome was basically to keep them alive, to keep them, safe from COVID. But obviously, there's a lot of other things that went on there. And if we go to the next slide, please. Logic models really can help us in identifying some of those activities and those processes, and understanding some of those unintended consequences and how they came about. So when you look at logic models, they all, they can be presented slightly differently, but they all tend to express a theory of change through if and then statements. So, the terminology sometimes varies, but these concepts, these basic concepts remain constant. So we look at resources, which we refer to as inputs as well in sort of services and programs. And, you know, the idea is that if we have certain resources that are needed to run a program or a service, then you can perform activities, you know, so that's the if-then relationship that sort of starts off there. Now, if you have access to resources and you can perform your planned activities, then you are going to, you know, accomplish some outputs, you know, for example, if we were saying that, you know, we, as part of a program, you know, you might want to deliver some education sessions, you know, outputs is very much about counting how many sessions you've delivered, rather than really looking at how those sessions were developed. So the if-then relationship is, you know, about the sort of one thing causing another. So if we have delivered these education sessions, for example, the theory is that in the short term, these activities lead to changes in understanding, in attitudes, and awareness. In the medium term, we then look at changes in behavior, individual behavior, and then, you know, sometimes also organizational behavior. And then the longer term, the theory is that we, you know, to reach, you know, certain impacts that you've set out, you know, we see more societal changes or bigger organizational changes. So if we have the resources, then we can deliver the activities. If the activities are delivered as planned, then you will reach certain outputs. If those outputs are delivered, you will have your short, medium, and longer term benefits as planned. So that's the very sort of nutshell of a logic model, but I'm going to give you an example in a minute as well to help hopefully clarify some of that. So if we have the next slide. This is the logic model that was sort of a classic logic model developed by Kellogg's, and it can be found on their website, and we'd be happy to share those links after the talk as well. And again, it just really shows an example of inputs, outputs, and outcomes. So when we break it down in this way, you can see that the very first thing on the left-hand side is that we start looking at the situation, which we refer to as the context, which is what we're going to be looking at in our literature review, and the priorities. And we try to understand what the mission and the vision was in terms of that COVID management. So that's all going to be part of the literature that we're looking at with the support of our advisory panel in sort of focusing it. When you read a logic model, you read it from left to right. So you look at, you know, the inputs and the outputs in the if-then relationship. But when you actually develop a logic model, we tend to start at the end and look at, well, what was the ultimate goal? What are the long-term impact that we're looking for? And we know that here, we know that it was really, you know, to safeguard and protect the older age group. So we have the sort of the start and we have the beginning. So it really is about untangling and identifying the bits in the middle. That's what we're going to be doing through the literature, through talking to our advisory panel, and also you know, interviews that we will talk a little bit about in work package 3. So the logic model is a tool. It's something that is constantly evolving throughout the project, and it really is about trying to clarify what you're trying to do, whether it's deliver a program or a service, or in our case, you know, identify what the intervention and the consequences really were of that COVID-19 management. So next slide, please. Oh yeah, so we're going to do a little silly example, and this really is very, very silly. So please bear with me through this, okay? If we can go to the next one. So this is an example of washing your hair. I'm sure everybody in the audience and in the panel wash their hair. So it's something that's familiar, and it's really just to show that this sort of very simplistic way of looking at things through the if-then relationships as a sort of causal chain of actions and reactions. You know, we take that simplistic model and try to apply it to very complex systems like health, social care, all those different factors that we are involving in this project. So, you know, even in a very simple example as washing your hair, you can see the complexities that we can start to untangle. So I'm just hoping it will give you a little bit of an illustration of what we hope to do. So if we go to the next slide, please. So my hair is dirty. It's not, it's crazy, but it's not dirty today. But, you know, let's say it is dirty. My family, my friends, my colleagues are complaining that it looks greasy. They're avoiding me. I have been told that using shampoo and conditioner when showering will clean my hair and make me look socially acceptable. So if I have the next slide, please. So in terms of the resources or the inputs that I need in order to perform this activity, in order to get my hair clean, I have identified that I need warm water, shampoo, and conditioner. Now, that's my interpretation of it. Others may, you know, say you don't need warm water, you don't need conditioner, but we'll get to that later. In order to actually wash my hair, I need to wet the hair. I'll do some lathering, conditioning, and rinsing. Next, the outcome is clean hair, and the impact is that I'm looking socially acceptable. I have improved interactions with family, my friends and colleagues want to be around me for a change. You know, my hair's not smelly. So in order to achieve that, I've made a lot of assumptions. First of all, the bathroom is not in use. Anybody who's got kids, you know, teenagers, who gets first into the bathroom, or whether it's your partner or somebody else. So the bathroom is not in use when I actually have time to go and wash my hair. Another assumption is that I actually have shampoo. The kids haven't used it all. My partner hasn't used it all. Another assumption is that I have a working shower. I also have time to wash my hair. I mean, how many dates have people skipped because they had to wash their hair? Takes time, as we know. And I have the function of both my arms. I haven't broken my arm, so I am actually able to do it. So even with that very simplistic thing that we're doing, there are a lot of assumptions around. And part of what we are doing when we are talking to people, when we are looking at the literature and the documents that we're going to be reviewing, is trying to understand what are the assumptions that have been made around putting in those guidance around COVID-19 management for over 65s. So we will be identifying those things. Next, please. So you can see that there's loads of complexities here now. So I got a few little clicks here, please, if I can have the first one. So we've assumed, you know, we go to the bathroom, but there is no shampoo. You know, that is what we refer to as perhaps a supply failure. You know, the inputs, the resources that we required, we don't have. And when you are putting together a program or a service and you are identifying what resources you need, is you know, it's essential that you have those. So we're going to be looking at what were the inputs that were required in terms of this management, COVID-19 management. You know, we haven't identified them all yet, but one of them, you know, one of the clear inputs is obviously the guidance around what people needed to do. I have shampoo, but I don't go to the bathroom. The phone rings, I get distracted. There's Amazon delivery at the door. I miss my slot because then there's a Zoom meeting and I can't wash my hair. So that's a delivery failure around the activities. Again, we're yet to identify these, but you know, we know that there have been guidance given. However, everybody haven't followed that. People have followed it differently, even down to the mask wearing. People, you know, have been wearing masks and not covering their noses. So there's loads of different things that can go wrong in terms of how the activities are delivered. Different local authorities have given different messages. There's been confusion with what's happening in Wales versus what's happening in England and Scotland. So, you know, there's loads of things that we need to untangle in that sort of even just the provision of the messages as well. Next, please. I go to the bathroom, I have shampoo and I forget to rinse. Now, whenever I sort of mention this, because I've used this example before, there's always somebody who giggles. Now, I can't hear anyone giggling, obviously, on this, but I know this happens. It is a real thing. You know, somebody forgets to rinse their hair out, particularly if we're in a rush. So, you know, we're talking about a partial delivery failure. Something's gone wrong in terms of the processes and what happened. And again, this could be linked to, you know, how the messages are delivered, how people have understood things as well. So I think we're coming up to the last little click here. So lastly, I wash my hair, but I still don't look socially acceptable. My interactions don't improve. So that's a theory failure. It may be that, you know, my hair is, you know, it's clean, but it looks a mess. I might have blue hair and I'm trying to fit in with perhaps rather conservative people, you know, so that's not socially acceptable. So, you know, there's loads of the context is really important when you're thinking about the theory and how all these chains, you know, these sort of causal chains are interacting. And what we are going to try to do is to look at those mechanisms in between to identify how unintended consequences can come from this sort of fairly clear theory of, you know, we're putting in guidance for people to shield so they can stay alive. What could possibly go wrong? Next, please. Yeah, so, you know, as you can see in our little examples as well, you know, there's loads of many layers of complexity just here, you know, inputs. You might need money to buy shampoo, you know, to go to the hairdresser, shower, water, you know, again, it's about the context. Who are you talking to? You know, is this somebody in the Western world? Is it somewhere else? There's loads of different activities required, research, getting advice, what is acceptable. I may even join a social media forum, you know, shampoo shopping. Which shampoo do you get? What if I get the wrong shampoo? And the outcomes, you know, really is about getting, you know, an awareness and understanding, so that knowledge, you know, and the impacts, you know, can be to look good, look socially acceptable, you know, increased relations. But it really does depend on what it is you want to achieve. So next, please. So, you know, around those assumptions is that it is actually feasible or even appropriate to determine what good looks like. You know, if I'm saying I want to look good, well, then we first of all have to define, well, what does good look like? So if we're saying in our context, you know, we're looking at the outcomes of staying alive, yes, well, there's staying alive, but as Emma showed you in some of the conversations we've already had, there is a difference between staying alive and living. And a lot of people have missed living. So that may be one of those unintended consequences that perhaps a bit more on the negative side. Next, please. So really the key aim by developing this logic model with our advisory panel is really to try and get a transparent and comprehensive description of what happened, you know, what the different intervention components are being assessed, and also have a common language between the research team and the advisory panel and wider stakeholders, because across different health and social care, you know, things can mean, you know, the same word can mean slightly different things, you know, in terms of impact, outcomes, outputs. We see that all the time. So it really is about being able to have that clear description that we can share with people. In terms of, yeah, just to finish, I guess I'm on the time now. Just to finish is that, so in terms of unintended consequences, logic models are particularly good at helping you identify some of those consequences. And, you know, I'll share a reference that's quite interesting, which is about dark logic modules, which is specifically about looking at unintended consequences when you're putting together a program or a service. Because, you know, our assumption is that if we do A, then we will have B, but there is a, you know, a magic black box like they have on the airplanes in the middle where all the magic happens, that we then are going to try and untangle and see what happens. Thank you. I'll hand over to Mari now.
Hi everybody. Yeah, my name's Mary Jones, and yeah, I work with Liv at the Centre for Health Economics in Swansea University, and I'm just going to talk to you briefly about our second mini project, which is looking at the costs and the consequences of the lockdown situation that we all faced in 2020 and are still continuing to face in 2021. And this comes under a discipline called health economics. So I'm just going to give you a brief introduction now to what health economics is and how it's useful in this context. Oh, I'm just struggling. Oh, there we go. My slides are moving now. Sorry. So health economics is based on the concept of scarcity. So we have, as human beings, have so many desires that we want to be fulfilled. We want to live long, happy and healthy lives. We want the same for our family and our friends. And ultimately, there's just never enough resource available to completely satisfy our desires. Our wants and our desires are unlimited, but resources, either human resources, financial, capital, environmental, are all limited. So the issue that we face is not whether we should prioritise things in the health service, but how. How do we prioritise? How do we choose how to spend the money? So big decisions need to be made, but what's the fairest way to make those decisions? And that's what health economics is about in a nutshell. So first of all, why do we need to make choices? First, we want our choices to be for the good of the patient. That's obvious, isn't it? So if you've got a patient who's suffering with some painful, debilitating disease, we want to improve their quality of life and their length of life, don't we? That's sort of the most important thing, isn't it? That we help our patients. Secondly, we want to improve the efficiency and the quality of the care. There's no point having inefficient care in the health service, and we want the care to be of the highest standard. We want patients to receive that care in the most timely fashion, and without having to wait a long time, if at all possible. Linked to that, we want to reduce waste. So I'm sure we can all think of situations in our own lives, whether either ourselves or people we know have experienced some sort of wasteful situations in the NHS. Sometimes you'll have a consultant acting as a junior doctor because there just aren't enough junior doctors, that sort of thing. There are situations where there's high waste, where money and resources wasted in the NHS. Fourthly, we want to ensure that our patients are seen in a manner that's both equitable and that it's got equality. So equality just means that everybody has the same number of resources, regardless of whether they need them or not. So everybody's got access to the same healthcare, but equity is slightly different. So it's when resources are shared and they're based on what each person needs to adequately level the playing field. So certain people might have access to more resource because they need more resource. So we want to make sure that our choices address both equity and equality, because those are obviously really important factors. Next, we want to make sure that we avoid every harm possible for patients and for staff in the NHS. And finally, we have to make choices because there just isn't enough resources to work without making choices. So why is there so much increasing unmet need in the NHS in Wales, or actually in the NHS in the UK? There are many reasons that are highlighted on these slides. The aging population, people are living longer. Often as they get older, they have more complex health needs. So they have more interactions with the health service, and therefore they put pressure on the NHS resources. There's also a decreasing level of population health. So we've all heard of the obesity crisis and how what impact that's having. Also, people are very stressed in their workplaces, and that can also have a huge impact on people's physical and mental health. And as well, we know that there are low physical activity levels, and again, that has its own bearing then on the health service. Staffing levels in the NHS are always difficult to manage, particularly with Brexit occurring. We've got even fewer doctors and nurses and healthcare support workers to go around. And of course, the same is true in the third sector of that also. There's also changes in NHS budgets. We know that each time the budget comes round, we're not sure what's going to happen. Our health going to get more? Our education going to get more? It's really difficult. There's changes all the time. The government has to make these hard decisions. New technologies are being developed all the time, and often they're much costlier than the old technologies. So we need to see if they're worth it or not. And finally, patient expectations are increasing all the time. People are holding the NHS to a higher standard than ever before. But of course, I've left one big factor out. One thing has blown all these things out of the water: COVID. The stress that the pandemic has placed on the health service is phenomenal, as we all know. It's been well publicised, and I'm sure you've all experienced it to a certain extent yourselves. So waiting times for elective surgeries are an all-time high. Many appointments with the GPs are either done virtually or on the telephone still. NHS staff morale is at an all-time low, and it's only November. We've got a long, hard winter ahead for the NHS. So in March 2020, the decision was made by Boris Johnson and Mark Drakeford to prioritise protecting the NHS over everything else. Do you remember the slogan that we had? Stay home, protect the NHS, save lives. So our government policy was to suspend all non-urgent NHS services and concentrate on keeping as much capacity available in hospitals as was possible. So in the current hospitals that we already have, and also in the field hospitals that were built to deal with a surge of COVID patients at that time. But what we want to know is, at what cost did that come? Okay, I'm just quickly going to explain to you the something called opportunity cost, which is one of the key things we think about in health economics. So when resources are limited, it's necessary to give up one thing to acquire another thing. So imagine yourself in the government's shoes. You've got to decide how to allocate funding. So this is just a little example that you find in a book by Morris, Delvin and Parker. So, and it's talking about the opportunity cost of IVF. So if we choose to give a lady IVF treatment so that she can have a baby, what else do we have to forgo in the NHS? So IVF's costs roughly £12,000 per cycle. So you've got options of how to spend that £12,000. So firstly, you can have one cycle of IVF on the NHS, which is brilliant. The next thing you could do with it is you could have a third of a cochlear implant. Now, a cochlear implant, for those of you who don't know, it's a little implant that gets placed at the back of the ear, and it helps a child who's deaf to be able to hear. So that's obviously huge. So that £12,000 will pay for a third of one of those. The £12,000 will get you a heart bypass. So if your grandfather or somebody needs a heart bypass, then that £12,000 could pay for that. It would remove 11 cataracts. So that obviously will improve the quality of life of 11 people who are sight impaired due to their cataracts. Or you could order 150 MMR vaccines for children. So we have to make decisions here. The IVF is fantastic, but you've got these other things. You have to weigh up which one would you choose, and that's the sort of dilemma facing the decision makers today. But of course, you could spend it somewhere else, maybe not in the NHS, but outside the NHS. And that £12,000 would also buy you half a junior school teaching assistant, so pay their salary for half a year, which obviously is huge and is really important in the education sector. And also, rather topically at the moment, it will pay for 2,000 school dinners for children. So again, it's got a huge impact. So you have to weigh up where you choose to spend that money. Each of these things are important. Each of these things are valuable and are worth so much to the individuals involved. Yet somebody's got to make this tough decision. Okay, we're going to have a quick game now. I'm not going to make you pick with those because that's a bit harsh. But we're going to have a quick game of would you rather. I'm sure you've all heard of this game. My kids play it with me all the time. Would you rather do this or this? And you have to choose which one you would rather. With my kids, it's normally some horrible way to die they choose. But this isn't that. So Kim, if you're ready to put the poll up. Okay, so would you rather spend £1 billion, which is how much it's going to cost actually to give us all a booster jab next year, or buy 70,000 heart bypass surgeries? Which would you rather do? There's no right or wrong answer. Okay, looks like everyone's, oh, look at that, 50-50. Well, that's it. That's almost, it's the perfect example. It's such a hard decision to make. People don't know what to do. And I, for one, am very thankful I'm not making these decisions, but just giving people the maths behind them. And then they have to make the decision at the end of the day. Okay, I'm nearly done. Sorry, just move on. It's not letting me move on, Kim. Have you got control? Oh, no, there we are. Right, sorry. Okay, so how do we make these difficult choices? We need to make our decisions using the sort of evidence-based healthcare, which is what I've tried to show you today, sort of health economics and looking at sort of effectiveness of different interventions. We need to combine that with clinical expertise and judgment, so what the doctors and nurses and care home staff think, the best available external evidence on clinical and cost effectiveness, so the literature, so what the scientific research tells us, that will allow the healthcare professionals with patients and other stakeholders to reach the best decision in a particular situation. So basically, it's a big team effort to make these decisions, because it's just too much for one person alone, because there's so many different factors coming into play. Okay, so just a final little warning slide. We can't only think of budgets, however tempting it is just to want to save money for the NHS or save money in any of our public sectors. We can't just think of money. We need to think about value for money. So with my little diagram here, sometimes it's worth spending a bit more. If we've got a cheap drug, but it doesn't work very well, then it's pointless. Our budgets might be happy, but there's no value for money there. You could have an expensive drug that doesn't work either. We've encountered that in our clinical trial work, which is even worse. But instead, we want every drug or every intervention that a patient has to have the highest benefit. And sometimes we do have to spend a little bit more to do that. Sometimes it's worth spending more to get the highest benefit possible. So I've just given you a brief introduction to health economics there. You might think, well, what's this got to do with the lockdowns and with how, which unintended consequences there were given that we had all these lockdown situations. But basically what we'd like to do is take the principles of health economics and apply them to the COVID-19 lockdown of the first one, the March to June 2021, and then all the subsequent lockdowns that we've experienced here in Wales. We want to look how much it cost the NHS to have the lockdowns in Wales. So we saved some money. We cancelled a huge load of surgeries. We cancelled screening services. That saved money in the short term, at least. But we spent a lot of money too. We built field hospitals. We vaccinated the population. In terms of the benefits for the older people who we are interested in this project, we want to explore the effects of that lockdown on our older population. So did fewer people get diagnosed with life-threatening diseases because they're afraid to go to the GP? Or when they did pluck up the courage to go, were they more unwell than they would have been had they gone previously? Did more people die of acute conditions because they were afraid to phone 999, or they didn't want to put pressure on the creaking health service? But of course, some good came for patients, for people from the lockdowns also. Fewer people did die of COVID than would have had we not had lockdowns, so that's what the mathematical modelling suggested anyway. We know that many people ate better. People were cooking for themselves again. Maybe that's not so true in the older population. Maybe they cook better than the younger population generally, but people also got out to do their walks every day. Many of us lived for that hour that we were allowed outside, didn't we? And that would have had an impact on their health, whether an older person or a younger person. Anecdotally, we've heard of all these things happening, haven't we? But we want to investigate them properly and really look into the impact that the lockdown had on these these people and patients. We've just seen in the chat today already that stroke services were completely suspended. Care homes were obviously incredibly badly affected. And we need to look into these things and to see where the real issues come in, if you like. So there are so many questions that need to be answered here, but we need help. On the advisory panel, we need people who can guide us as to which are the most important questions to answer first, because we don't have an unlimited supply of money to answer these questions, if you like. So we need to narrow down our population, as Liv and Emma have said, to a specific group that we can focus on and just look at the issues that affect that particular group. So we've had a few ideas already today from the chat, but yeah, if you have any more, please do get in touch and let us know what you think is the most important group of people to look at, or the people who are most affected in the older population. Okay, so that's me finished now. I'm going to hand back over to Liv now to speak about Work Package 3.
Hello, back again. Thank you, Mary. I think that was really well laid out. I can see there's an interesting comment in the chat there as well. I don't know if you want to have a look, Mary, and we'll come back to a lot of the questions at the end, as well as try to respond in the chat. So like Mary said, it's who are we going to really focus on, and that is one of the first things that we are looking at. But part of that is capturing the experiences. So let me see, does this work for me now? No, I think I might. Oh, did I do that? So what we are going to do, and this work package is going to be led by our colleague Maria, who couldn't make it today. We are going to be talking to people. So we're going to carry out qualitative interviews, which is basically face-to-face interviews if we can, but via Zoom if we can't. We're very aware of how people might be excluded if they're not sort of digitally involved, so we're able to access Zoom and things. We have seen that as one of the issues, for research during COVID. So, we are going to do our utmost to make sure that we are able to reach as many people in as many different circumstances as we possibly can. the aim of the interviews is really to explore people's experiences, and we expect we will be talking to people, you know, all the people, their carers, and those living with dementia as part of the subgroup that will then be a bit more focused, you know, as we've discussed them with our advisory panel. So we're going to be talking to them. We're going to be developing some topic guides based on the reviews and the other work packages ahead of this, that will guide those conversations. And, you know, we're obviously inviting input to those kind of questions as well, though we do have some questions that we expect we will be looking at, or some topics that we will be exploring. And Emma's just going to tell you a little bit about them now, because she already introduced them a bit when she set us off earlier on today. So Emma, have you got those questions?
Thank you. So some of the questions we may want to ask. So when the outbreak first, when the outbreak first happened, your home was deemed to be the safest place to be. People stayed in care homes, lockdown, visitors weren't allowed in. What was the impact on people's health and well-being by staying at home, and how was this experienced differently between the different groups of people over 65? Some people over 65 are fit and well, but so they may not have had health impacts, but not being allowed out or socialise, go to the pub, meet with family and friends, go out for a swim or cycle or a walk. Will have been experienced completely different to people perhaps who have got long-standing health issues, which if they caught COVID, this would have been catastrophic. People living in care homes where the pandemic could have wiped a care home out. So these are experiences we want to capture in these questions. It could be that people living in rural areas or inner cities experienced it differently. And whether you have neighbours who can help you, or family and friends. So what about older people then, who depended upon others to provide support and care to others? You know, I can think of some examples now where, well, my mother, she looks after her older brother who's 85. She doesn't live with him, but she's got health problems herself. And her experience of having to go out shopping and do various things and try to protect herself, and then her older brother again, you know, this was the impact on this is going to be huge. Some older people care for grandchildren, and to have grandchildren then not being able to visit. So, you know, schools were closed, lunch clubs and various things were closed. So grandparents really missed out on the social interactions with their grandchildren. Day centres for older people who needed the respite, so carers needed respite for them. You know, the withdrawal of all this social contact and social support outside of the home. What was the impact of this? So how were social distancing measures experienced by older people? That's another question we'd like to ask. So did it result in social isolation? And for who? Some groups of older people, perhaps not others, and why? And what policies could have prevented or anticipated this? So because of the pandemic, we found new ways of connecting, but these didn't include everyone. So some people were still excluded. Some people who were not digitally connected were excluded. And how can we make sure that we include these groups of older people who might be at more risk of poorer health and well-being outcomes? So, and then they're more dependent upon care and support. So these are just some of the examples of the questions that we're going to ask. But of course, we are going to be looking at specific populations, and we will be tailoring some of these questions to the populations. Okay, so I'm going to pass you over now for work package 4. I'm not sure if Gideon is here.
Hello, I'm Gideon Calder, and I'm going to talk for the next few minutes about our 4th work package, which is the one on fair prioritisation regarding older people in Wales in future health crises. So a little bit about the question at stake in this work package and how we're going to be tackling it. So firstly, the question at stake. What can we learn from the evidence gathered in work packages 1 to 3 on responses in Wales to the COVID-19 pandemic about how best to ensure fair prioritisation for older people in the case of future public health emergencies or exogenous shocks? That's the question on the table. And the way in which we're going to tackle that question is by devising an ethical framework. Now, the idea of this ethical framework is that it'll be something which will be really genuinely accessible and usable by decision makers during future public health emergencies, and also something which will be understandable by what you might say is the public at large. And we're going to put this thing together by basically drawing out findings from the first 3 work packages that you've just been hearing about into a framework which is very clearly evidence-based, which is, as I say, accessible and user-friendly, but also, we hope, kind of adaptable and flexible and nuanced enough to address what, of course, will be very complex situations involving competing considerations, so different kinds of priorities which might weigh on our decision making. So we're expecting all of that. It's a complicated world, and the pandemic makes it more complex, and it makes our decisions harder to make. So we want a framework which makes making those decisions not easy, but clearer, and particularly makes it easier to articulate the justifications for our decisions when we are in those extraordinary circumstances. That's the general plan. Why is all that important? Well, it's important because when resources are scarce, when systems are under pressure, for example, fair prioritization becomes even more paramount than it would otherwise be. So being seen to make decisions which have been thought through in terms of why resources are being channeled this way or that way, why decisions are being made as they are, is especially important in periods of public health crisis. And we can't, like I say, magic away all the difficulties, but what we're hoping is that a framework like the one that we're going to produce will help people make decisions in a clearer way, and also help highlight the things that they need to discuss. So it's not meant to be like an algorithm which somehow magically produces the right answer in terms of what to do. That's not the idea of this framework. What instead it's going to be designed to do is to give people some parameters and some discussion points and some issues, some themes to deliberate with and about with other people. Because once we have those, once we know the kinds of things which are best to concentrate on, then we've set up the kind of circumstances in which people can navigate their way through all the difficulties and come up with decisions that they are happy with and which they feel that they could explain and justify to other people. So what kind of framework do we mean if we mean a framework which is done the right way? Well, this is basically what we mean. A lot of the time when we learn about ethics or about decision making, we learn these things in terms of top-down rules, or rules which were conceived in advance, principles, regulations, which we would, as it were, just follow regardless of the circumstances. That's one way to think about how to make a decision. But what we are aiming for is something actually quite different. It's something which is explicitly evidence-based. So instead of wheeling in some kind of all-purpose preconceived set of parameters and ideas about how we should make decisions, we'd like our framework, to be based on the evidence which we have very specifically found in Wales in these circumstances about how harms occur to people and about how the decisions that we make in certain kinds of positions of authority can help address those harms, minimize them, and create circumstances in which people benefit to the fullest possible extent as a result of the decisions that we make. And we think a large part of what helps decision making in these areas is consideration of fairness, because if no decisions are perfect, the world isn't a perfect place. Things will always be messy and difficult. There will always, to some extent, be winners and losers. We can't just ensure that everybody has the most fantastic time during a pandemic. But what we can do is, in good faith, to the best of our abilities, try to make decisions which are fair. In other words, ones which we can actually justify to other people and explain with some degree of transparency the reasons why resources were allocated in these kinds of ways. And we'll be using a quite well-established framework, which was devised by the Newport Fairness Commission, which was basically designed precisely for this purpose. So all sorts of decisions made by local authorities under different kinds of circumstances about all sorts of different things. All of those decisions could be helpfully articulated in terms of basic principles of fairness, which we will adapt and apply to these circumstances. So what will it look like, this framework? Well, it'll look like a practical reasoning tool. It will be something that you can pick up and use. It's got to be user-friendly, and it's got to be adaptable, and it's got to be appreciated by different kinds of audiences. And the best way to achieve that, we think, is to have an overall set of principles which are relative, like headlines, relatively clear and simple and short, with more complex layers underneath, which include questions and answers, and how presented in such a way that it helps you kind of navigate your way through different kinds of levels of decision making. So it's a combination of the complex and the simple, because we think that that is probably what's best suited to a pandemic situation, for example, or another kind of public health emergency, which is precisely in some ways characterized by some quite simple overall priorities and some very complex details at ground level in terms of how those priorities might be addressed in this or that kind of case. And our framework will be for policymakers, so people who want to think about things in the grandest possible way, but also everybody right the way down to coal-face decision makers in all sorts of different roles. So we want it to face both ways. We want it to be a way for policymakers to think about where the priorities should lie, but absolutely just as much, in fact, maybe even more so, that practical decision-making tool where in this or that setting or scenario, somebody can draw it down and it will help them make a decision to the best of their ability, given what the circumstances allow. Now, if we've pulled all that off, work package 4 will be complete, and we think that that will be a really good way of doing justice and kind of to the culmination of all the other kinds of findings that we will have reached during the study. If we can find a way of translating all of that wisdom and knowledge, all of those insights that we've gathered into a tool which will actually help us respond more effectively and fairly in future public health emergencies like the ones that we've just been experiencing. Thank you very much.
Barry, I think it's over to you here.
Sorry, Kim. Yeah. Okay, so yeah, we were just gonna sort of finish off by saying how can you get involved in the project. So the obvious place really where we really need people's input is into the advisory panel and selecting our population of interest. We have quite a few public members already signed up, but we would be really interested if anybody from the third sector or NHS or academia would like to get involved. Yeah, then please do let us know by just writing in the chat, or you can message myself personally on the chat, or Emma, or well, any of the presenters. And yeah, we would love to have you on board to be on the advisory panel, and it would just require a couple of meetings. I think it's 3, isn't it, over the course of the 2 years. You'd of course be acknowledged in any publications that we got from it. So if you're interested in that, that would definitely happen also. So yeah, if there's anything that you'd like to sort of have your input with, we'd love to hear from you. We're really grateful for everything that's already been said in the chat today. It's been really helpful and useful to us. And yeah, we'd love to follow up with some of you about that. But yeah, if anybody would like to get properly involved on the advisory panel, then yeah, please do let us know. Well, that's lovely. I can already see one person. That's fantastic. But if anybody has any questions now they'd like to raise about what we've spoken about today, that would be amazing. Oh, Gideon is here. Sorry, it's my fault. He's come in as Maria's name. That was my mistake. Yeah, so we're here for any questions if anybody would like to ask anything. Yeah, please go ahead.
Brilliant. Thank you, Mary, Liv, Emma, and Maria vicariously, and also Gideon under Maria's name. No, thank you all very much. That was absolutely fascinating. And what a brilliant and really important project. And you can see how important that project is in the amount of chat that's that your project's generated, I think, in the chat box. I'll try and sum up some of the chat and ask a couple, just 2 questions I can make from the chat that's come through so far, I think, which would be really important to look at. And I thought it was great that you managed to give some really interesting examples of the kind of things that are going to happen, some really good examples of how you can make health economics be more palatable and more understanding. Great, Liv, to do an example using washing your hair. So from sort of social care to social hair, I thought that was nicely done. But yeah, it made it nice and easy. But just, I think you've got a really tough task on your hands with this project, as you can see from the chat. And I'd just like to know, because lots of people have mentioned lots of important things that they've come across during the pandemic that have happened to older people. So Andrea Nicholas-Jones mentions, the increase in abuse that older people have faced. Julie Thomas mentioned stroke patients not getting support, and also, people living with dementia couldn't attend their events, let alone their healthcare appointments or memory clinics and things like that, which has impacts on carers as well as people living with dementia themselves. Steph Green, of course, mentioning unmet needs in care homes, things. So, and you've brought up your own sort of ideas, but just how are you going to go about prioritizing some of those issues? And I know you're going to involve people in doing that, but what will be the mechanism to work out which populations and which topics to look at? I mean, Daisy mentioned as well on there, the oldest old being really important to engage, but how, so populations and topics, and I know you've got a work package on it, but have you got any idea what mechanisms you'll use to reach those decisions?
Emma or Liv, this is probably best for you to answer.
Nicely passed over, Mary.
I think Emma's already passed the baton over to Maria, who isn't here, in terms of sort of reach. I did see in the chat that somebody, when we were talking about the oldest old, I think prioritization, we've got that advisory panel and we are really going to rely on them in that beginning to help us focus. We really need that. When we spoke to the public before, our lay members that helped us through both stages of application, they were very clear. They wanted to keep it wide and they really wanted to help us with the definitions of the different things. First of all, they told us they didn't want to be called vulnerable elderly, and I think that was a really interesting message for us, because we were quite focused on the protecting the elderly, and they came and said, well, we're strong, sociable people. We want to be out there doing things, and it really sort of, helped us think about those different consequences that perhaps we hadn't really realized. So having the expertise that we're seeking now for our advisory panel, we are really going to rely on that, the literature review. It will all come together. We will have to make some hard decisions in terms of those priorities. We can't do it all. We only have 2 years as well. But I think that's one of the sort of things we're hoping is going to be a success of this collaboration, because we're coming from such different backgrounds. We all have our own sort of perspectives, but it's about bringing that together with the public. So I think I've tried to do a really good politician speech here and not answer the question, but circumvented. And I think, we really are trying in this first few months now, we will know by January, February time where we are actually going. You know, what we are thinking already is that, you know, there may be follow-up work from this. There may be other projects that we will need to do. And I think that's probably the key thing here, is that we're starting out, we're mapping out what we can do, and then we'll build on it with other projects. So, you know, funders, look out, you know.
No, I think that's a perfectly responsible and sensible answer. And I think really, given the dearth of information out there at the moment, you know, concentrating on anything that people have brought up today, let alone, coming from older people themselves, would be valuable anyway. So I think that's really good. And the other question really comes on a couple of points made in the chat as well, particularly Jill Toms mentioned, you know, that perhaps it isn't quite business as usual with regards to the way economies are working or finances are working in healthcare at the moment. You know, is it possible, it made me think, you know, is it possible to use the same usual social return on investment or cost benefit analysis or other economic analysis tools that you would normally use during a pandemic situation? I mean, do you look at it differently, or is it the same kind of process?
I think we could start with the same process and then put a caveat around it that we do need to look at it differently, because of course something had to be done instantly, quickly, without thinking about cost effectiveness, basically. So we're just sort of going to start off on the normal route and just see where it takes us. We know the lockdown, well, just thinking now that it's not going to have been a cost-effective intervention, but it's those unintended consequences that we want to concentrate on. So of course it's not cost-effective, but people's lives were saved, so therefore it's a good thing. But we need to see, well, what were the other unintended consequences? So the good consequences were that not so many people died of COVID, but the bad consequences, there were so many that we do need to really look at more thoroughly. So we will start down the usual route of costing everything up, but yeah, it will, that'll just be an interesting exercise, if you like, at the start. And then we'll need to see, well, the outcomes are going to be where the real interest lies, as you said. They had to do something, didn't they, quickly?
Yeah. And can I just add, I think that will be one of the outputs really for us, is that it's about those processes. We want this to be quite transparent, you know, like Gideon was saying, you know, we want to bring that evidence, you know, the real evidence in Wales. Like Mary's saying, we're going to cost it up as we normally would, and then we are showing our learning, you know, that is part of this project as well.
Yeah, absolutely. And that's probably what my final question was going to be, based on the chat. Again, Philip Bell put a really provocative question in the chat, and I think it's perfectly fair enough to ask that kind of thing. And you know, as a researcher spending public funds, we always ask ourselves, you know, what is the purpose of doing this? Do we expect another pandemic? Or actually, what made me think is, especially from what you've just summed up there as well, is there's lots of learning from this, even for a non-pandemic situation, about how we deal with allocation of healthcare, social care costs, and even, you know, new models of healthcare and social care cost benefit analysis and things. So did you know, summing it up, you know, what do you see as the main purposes coming out of your work?
Mary is the lead.
I think what the main purpose really is Gideon's work package at the end, how it brings. So mine is sort of very mathematical. We're looking at just numbers and what happened in a quantitative way. You've got Liv and Emma finding our population, first of all, which is obviously the most important part. Without a population, we don't know what we're doing. And then we'll have Maria coming in, interviewing people, so to add sort of meat to the bones, if you like. So my work's going to be just the numbers, but hers is going to be the qualitative side, and to see, well, what did it really mean? These numbers are fine, but what did it really mean to these people? And then Gideon's going to bring it all together then to give us sort of our overarching sort of framework that's brought all this evidence that everybody's generated and found together. So I think probably Gideon is best placed to just feel this bit.
But I think, well, thank you, Mary, for bigging me up there. it's really genuinely painful listening to video recordings of yourself, isn't it? Blimey. Yes, I won't do that again now. I think I sound like James Bond, and I actually sound like Daffy Duck or something. Anyway, yeah, I think that's right. So, I mean, you could find out a lot, couldn't you, without translating it into kind of future learning? And I think that in some ways, it's going to be really interesting to find out what is in our framework, because we just don't know what will be in it, and if it would defeat the whole purpose if we did. So, we're not going to know what it looks like until it emerges. But what will emerge will be hopefully a way of kind of crystallizing the most important lessons learned through the whole experience of this. And I absolutely agree, Charles, that the way I was talking about it in the pre-recorded bit, it made it sound almost as if, well, the next time a big wave like this hits us, we'll know what to do. But it's not only going to be about the next time there's literally a big public health emergency like this, because there will be other kinds of learning there, because the kinds of ways in which we prioritize are they go, that all of that goes on just in everyday decision making at all kinds of levels. I think it would be really, really weird to treat the pandemic as somehow completely exceptional in that respect. What it really did was highlight lots of good and bad practice about how we normally do things, as well as giving us some really difficult, different circumstances to respond to. So yeah, I hope that there'll be a lot in that framework for wide use in different kinds of ways. And I hope that, as well as being used by people, it will provoke a bit of a conversation as well. I mean, it would be good if people found it, in some ways, if people responded to it and said, well, I think you missed a bit out, or actually you didn't put enough stress on that side of things, or whatever. I think that would be a really helpful dialogue to have about, because of all of the issues involved there. So yeah.
Absolutely. We're just about coming to the end here. If you've got 1 more minute, perhaps I'll try and just pull together this last question from that Daisy mentioned. It builds a little bit on what we've said before, because she's right. A weakness in a lot of social research and policy making, those who volunteer and speak out, they're the strongest and most cognitively able a lot of the time, and therefore it's their voice that you hear in a lot of the agendas that we set about. Whether it's policy or practice, or even in lots of research terms, it's their voice that often gets heard. So things like bereavement and dying well, which have a big impact on older people, are not really examined in terms of impact on mental health and services. But I think this is nicely put, but as a nation, we are all grieving in many ways. So it may be worth looking at this. And it's a bit like we said before, it's about, we've got models and we've got business as usual kind of things out there as it is at the moment, but this gives us a chance to turn things on its head a little bit. Your project does. It gives it a chance to be a bit pioneering because of the interruption, if you like, in normality that lockdowns given. This gives us a chance to look at things in different ways and support people who wouldn't normally be supported, or listen to those voices on the margins that tend to get lost, who now have had to be heard because they're being, noticeably lost in all of this, or, dying and losing out in all of this. So I think there's just a chance we can do something quite differently, or you can do something quite different. Anyone got any final comments on that?
No, I agree, and I think because we all bring such different perspectives in from our backgrounds and our affiliations, I think we are going to have, like you didn't say as well, we're going to have more questions perhaps at the end than answers. But I think that's the good thing about this as well, is that there is going to be a lot more to come. This is the beginning. We will have an outcome, but that's going to be a short-term outcome. We are looking at this in the longer run, and I think it's so important to start those conversations and really reach those people. And I think that's where we've got the expertise of the aging. We got the prioritization from the health economics. We got the ethical framework. So we're hoping to bring all that together. But yeah, probably more questions. Yeah.
And I think that having the different stakeholders and having the range of stakeholders with 5 members of the public involved in the process as well will really help us thrash out these priorities.
Yeah.
and I know Emma mentioned it before, I just say this as an end, we were so impressed. We've had such fantastic support from our lay members throughout the stages. We were really, really fortunate. But
oh, did we lose? Yeah. Oh. But yeah, a nice way of summing it up really there. I think we've got to finish there. We're running out of time, but thank you very much again, Mary, Liv, Emma, Gideon. What a brilliant, challenging project you've got ahead. But yeah, with the help of a good stakeholder group with lots of older people involved in as advisors, I'm sure we'll come out with something very, very exciting from it. Oh, and of course, not to forget Maria, who couldn't be here as well as part of the team, and Andrea is part of the team as well. But I wish you all luck in the project, and we'll support you through CADA where we can. So we'll invite you back to let us know how you're getting on in a few months' time. Be really good.
Thank you very much, everyone.
And
thanks for having us.
Thanks to the audience for good questions, and do fill in the feedback form as posted on the chat, and probably will be sent out on email to you all as well, because that helps us plan for the future. So thank you very much, and look forward to seeing you at the next seminar. Thank you.
Thank you.